Going to talk about expanding access to palliative care through Medicaid, one state at a time. And she's the founder and chief executive officer for TFA Analytics, strategic advisor to the Coalition to Transform Care. So, Torrie, thank you. Thank you so much for allowing me to come here from the other Portland, Oregon. I'm Torrie Fields, and I spend the majority of my time looking at the macro view of things to really support providers. A lot of you guys are providers in the audience, and so everything that I'm talking about is because of you, because of all of you and your passion and your ability to take care of patients really well and your need to be recognized for the value that you deliver. Just want to start out by asking, when you think about expanding palliative care benefits and think about Medicaid, are there any burning thoughts or questions that you have just right off the bat?
The Medicaid recipients deserve it.
Did you say do Medicaid recipients deserve it?
That they deserve it. Yeah.
Oh, that they deserve it. I hope they do. Any concerns? Oh, good. What's that?
I said this concern about Medicaid.
You're concerned about Medicaid. Aren't we all right now? I'll tell you why maybe this is not something to be so concerned about in this conversation. I can't change everything, but somebody already asked me about business case, so there's a little bit about that. Were you going to say something funny? No, she's thinking aloud. Okay, I'm going to start by saying, why is now the time for focusing on these benefits? I'm going to give the bigger answer here, but I'll start with my own personal experience. I was on my way to medical school. I had just quit my job, and I was diagnosed with cancer over the phone by my physician. And so instead of becoming a doctor, I went into finance because I became a pre-existing condition overnight, and I was diagnosed with cancer the day I lost my health insurance. It took me 13 months to get access to care, at which point my disease had spread, and so I was a little bit more of a complicated case. And the only reason that I actually was able to get access to coverage at all was because I joined the federal government as an IRS employee. And I learned all about taxes and finance while going through cancer treatment. And you never know when you're talking to a policymaker or a finance person like me what their story is or how these things have impacted their lives. I'm currently a caregiver for a young person, my partner who is newly diagnosed with glioblastoma, who is the head of a nuclear power plant. And he's very, very smart and thought he knew all the words. But healthcare is a different language, and it is difficult to navigate, even when you have a master's degree in nuclear physics and all the money in the world. You still can't navigate this unnavigable system. So that is why we need better access and education about these services. I am a Pollyanna. You will learn this about me through this talk. So I will tell you that COVID did us a favor in identifying where the healthcare delivery system goes wrong for people with serious illnesses. In addition to that, medical innovation has made palliative care even more important than ever before because people are living longer with serious illnesses. They have more access to more complicated treatments, and those treatments are expensive. And so look at that. Somebody's got to help you navigate things that are getting more complicated and more expensive, which creates a business case overnight. The illnesses that used to be life-threatening or even life-ending are now chronic diseases. So I am standing up here, a 2-time cancer survivor, able to do a job with all of my experience and memory of how horrible my treatment was. And now we are a rising group of individuals who are living longer with a voice, able to return to work. And then you look at COVID. COVID actually just changed how quickly we access new technology, how quickly we deliver new interventions, and on the national level, we started talking about risk and risk tolerance. So if you're high risk, stay at home, stay inside a bubble. If you're lower risk, you're able to do different things. And we were all, without our knowledge, weighted in terms of how quickly we could access the COVID vaccine, which is risk scoring. And that's something that allows us to start taking the things like prognosis away from services. And that is really important to things like palliative care. We also learned through COVID that people have other problems other than just physical ailments or medical issues. We are actually people at the end of the day. We're not just a disease. And so that actually leads to things like talking about financial toxicity, talking about social isolation and loneliness, talking about mental illness or behavioral health issues right off the bat. And when you have an interprofessional team, my slides say interdisciplinary, so I apologize in advance. But that when you have an interprofessional team, you're actually able to address people's needs a lot more holistically. And healthcare is no longer just medicine. It is human-centered care. People with serious illness then need comprehensive care. They need care across all settings if we want them to stay out of the hospital, if we want them to stay safe with their serious illness. They need holistic, whole-person care that addresses all 8 domains. And they should have personalized care for them and for their caregivers that gives them the right care at the right time. And that's just good resource allocation. So it may be the right thing to do, but it's also good financially to allocate resources in the best way possible. What's really cool and is new as of May 7th of last year is that palliative care was categorized as a preventive service by the Centers for Medicaid Services. And that was through a state plan amendment or a budget update for the state of Hawaii. And this was the first time that CMS came out and actually categorized what palliative care was. It was my surprise when we went in there with an argument that palliative care was a little bit medical care, a little bit clinical services, and a little bit hospice services, that they came out and said to us, wait a second, didn't you just say that palliative care prevents suffering? Wouldn't it be a preventive service then? Yeah. Okay, that's the better argument. Let's go with that one. And that can help with some of the messaging conversation, right? Oh, isn't palliative care like hospice? No, it's actually preventive. It helps you manage your pain and other side effects from treatment, and it's something that prevents unnecessary suffering. Awesome. It goes down a little bit easier with your oncology and cardiology colleagues, right? You're just adding something that helps alleviate suffering. So Hawaii was the first state to introduce palliative care as an essential health benefit for Medicaid. And they did that through a state plan amendment process where it was added as just a standard benefit that every managed care plan and the state needed to offer. And what we're seeing now as part of implementation is that the private health insurance companies are also starting to pay for palliative care, because now they have a framework. It's not so variable anymore. It's pretty standardized. And that's what they needed. They just needed a cookie cutter. They needed a cookie cutter. And so if you think about it, you all want to move to Hawaii now for many other reasons, because they are actually offering interprofessional, team-based community palliative care through almost all of the insurance companies there. Yep. It has myriad other problems now that it's an implementation because it's brand new. But you can do it too. Actually, many states are working on doing that. So when you think about how far we've come in the 2000s, we have 22 states that have advanced legislation to expand Medicaid benefits to include reimbursement for community palliative care services in one way or another. They are all in different phases of doing this work, and the Johnny Hartford Foundation actually funded 6 states to get technical assistance through a policy institute to work on developing this plan for palliative care benefit design. And Maine was one of those states to be a participant for the last 2 years in this policy institute. So we're taking all of the things we've learned from Hawaii, all of the things we've been learning for 7 years in California, and really starting to roll this out statewide, nationwide, state by state by state. Some of the states are using the state plan amendment framework, which is similar to what we did in Hawaii. Others are actually expanding things like EPSDT for kids to make sure that palliative care is seen as a medical necessity for seriously ill children. They're looking at expanding home and community-based services, which if you're hearing anything about 1115 waivers or things like that, that's the form number for home and community-based services. And certain states have elected that route. You have Ohio that actually just this year rolled out palliative care as part of their dually eligible program. That's part of the dual alignment program. And they're requiring all of their Medicare Advantage plans to offer palliative care as a standard benefit. And then you have other states that are looking at expanding their master plans on aging, expanding PACE programs, and adding palliative care as a component to their health home model. Maine is a health home state, so this is a great opportunity or option for Maine here. And what we saw was that the American Rescue Plan Act, which is some of the funding that put on this conference here, actually reinforced the mission to expand palliative care activities across the country so that if there were another COVID, we would be prepared. So when you look at this across the country, you would anticipate a place like Hawaii or California, you know, those blue states that are really progressive, that do a lot of new and innovative things. Places like Oregon that passed House Bill 2981 to require all primary care medical homes to have palliative care included. But I mean, there's Texas, not a blue state, doing interesting stuff all around with healthcare, right? You know, you have a concern about Medicaid and about what's happening at the federal level about some of these issues. Well, when you have places like Kentucky, Tennessee, and Texas coming on board, and then Ohio doing something for dual eligibles, we know that palliative care actually may just be a bipartisan initiative. Not only is it the right thing to do, but somebody said earlier, it has a good business case. It's proven to save money by doing the right thing. So, why do we want to develop palliative care benefits at all? I think we know the top part here. Palliative care has been proven since the Temmel studies, since all of the other studies that have come out, to control pain and symptoms, to help patients and families achieve a sense of control, to relieve burden on family caregivers, so that, I'm not just the palliative care team for my loved one. And it gives people more time at home, also known as out of the hospital. And if you reduce one hospitalization, I'm pretty sure you can pay for palliative care, right? You will never be as expensive as a 5-day hospital stay. Medicaid agencies are looking at population health approaches to rolling out new benefits and programs. And what Medicaid agencies are looking at are very similar goals, but just from the macro level. So I'm able to add this one line here. It used to say expand health equity, but it had to change my language as of the first of the year. So I took health equity out of my slide. But palliative care now is a preventive service for Medicaid. So it prevents unnecessary suffering for people and their caregivers. And that is the language that CMS gave to me. That is not language that we gave to CMS. So I'll just feed it back to them. In addition to that, states want to improve access to high quality care for people with serious illness, this very high risk population. They also want to improve quality of life for people and their families, because happier people are better for the community. We want to decrease the burden for people's, the symptom burden for patients so that they can continue active treatment. And at the end of the day, we want to decrease avoidable utilization and spending. So as Connie was saying, if somebody's going to the emergency department because they don't have an alternative, that is not avoidable. We're talking about what is actually avoidable here. Things that can be managed through anticipation, through prevention. And because we have such an uncoordinated, broken healthcare system, doing the right thing reduces spending. The hospital is a very expensive place to be, and it's also pretty risky. What we have found in going through and working on palliative care benefit design with multiple states is that something you guys all know very well. There's no standard palliative care benefit available in any setting. Hospice is a benefit, and it is a setting where palliative care is delivered, but there is no standalone palliative care benefit for any setting. CAPC has reported that palliative care is being delivered in 68% of hospitals with over 100 beds, most through an interdisciplinary team. And when you ask CMS, they say that that is actually included as part of the DRG payment to hospitals. So they feel like this is something that's kind of like already covered under your standard hospital benefit. We're seeing that there are certain places where a palliative care consultation is even mandatory, like when you're placing an LVAD. And so we're seeing hospitals that do LVAD placements have palliative care teams. Look at that. So if you mandate it, they will come, apparently. The bigger problem, though, is when you get into the community, and very much what Connie said about primary palliative care versus specialty level palliative care. There are some palliative care assessments and consultations that are available in the community setting. But again, that is primary palliative care if you don't have an interprofessional team or people who are coordinating services. These are core components, critical components of palliative care. And that's the specialty part of this. Individuals who are specialty certified and trained, who can provide pain and symptom management in addition to care coordination. And what's challenging for state Medicaid programs who are trying to build these things out is that palliative care programs open and close based on access to funding. And so there's varying capacity across a lot of communities. And we like to talk about this in the palliative care space as a chicken or the egg approach. Do you get the funding, or do you build workforce capacity? And what I can say is that if you build it, workforce comes. Maybe not patients at first, but if you start reimbursing, we can actually pay for staff. And that's an important thing to think about when you're engaging with your legislators or you're engaging with your state policy officials, and you say things like, we don't have capacity to deliver palliative care. I would encourage you to say, we might be able to have more capacity with standard reimbursement. Because that doesn't create the limiting belief. That is a self-fulfilling prophecy. What we're finding in states is that there's a major difference between advanced care planning, primary palliative care, or goals of care discussions. And that in addition to the need for reimbursement for a team-based approach to specialty palliative care, we also need to start paying for assessments to be completed. And that will allow for, providers to actually assess for palliative care needs, perform goals of care conversations, and then refer to specialty palliative care partners. And that's something that we're doing in Hawaii. We also see that there is a huge gap in care when you're talking about community palliative care services. And a lot of the time, state policy officials think that there are so many benefits available to people with serious illness, including things like home health and hospice, that they might not need to build out another benefit for palliative. And so that's the role that you can play as a palliative care provider, is to talk up the benefits of your services, identify what the services are that you're delivering, and what the treatment goal or the intent to treat actually is, which is very different from home health and from the hospice setting. States are finding that there are a lot of different policy routes that you can take to sort of slit palliative care into what you're doing. There's the waiver route, which is like a pilot. There's the legislation route, which is what California did. They wrote a bill and then mandated that all insurance companies pay for palliative care. You have your state plan amendment route, which is a budget amendment that gets filed by the state with CMS. And then you have the slip it into something I'm already doing route, which means that you can add palliative care to health homes, you can add palliative care to value-based purchasing, or to your access to MLTSS, so long-term services and supports. You'll see here that there are different requirements, benefits and drawbacks to each one of these. But I'm really excited to say that now there's an opportunity that we can have and engage with the federal government about palliative care as a standard offering. What we had to prove in Hawaii for that state plan amendment process is that there was enough capacity to deliver palliative care statewide. And that was a very difficult process, since it's very hard to find palliative care providers when you don't have like a coordinated list of them. So stand up and be counted as part of this, these policy changes in the state. And don't be afraid to engage with your Medicaid program to tell them about what your capacity is, because that's a real critical component of building out these benefits and programs. So I'm an actuary, I do finance, and that means I just do data all the time. My team likes to say that I teach nurses Excel. So I'm going to try and make this fun for you, because I like data a lot. And it is really hard to make a palliative care benefit. To put all of the things you do into a standardized product is really hard, especially when you keep saying, Patients need different things. Everybody has an individualized care plan. There's no standard definition of palliative care. This is very risky for data nerds like me. So I'll give you just the brass tacks of what your health plans are looking for and what states are looking for when building out these programs. The first is your classic supply and demand. Are there enough providers to take care of all these patients? That's what sufficiency means. I'm seeing worried faces, right? Now, the benefit here is that most people don't know what palliative care is. And when they do, they think it's hospice. So the first couple of years, you're going to have fewer people accessing palliative care than actually needing it. And so it allows you to actually build out your workforce as you're starting to get reimbursed for it. You can start somewhere. You can at least start with the hospice population by delivering care upstream. We're also looking for cost and performance information. So one of the challenges is that if you're delivering palliative care as an interprofessional team, you're only billing for your billing clinicians, right? Which means that if we were to look at the claims for palliative care services, we would only get about, what, 30% of the story? Because chaplains do not bill, social workers do not bill, nurses do not bill. So what we need to get a better understanding is your costs. How much does it cost to deliver an interdisciplinary team, an interprofessional team that includes non-billing providers? So the more you know about your program, the easier it is to give you the money for that program. That makes sense? Mm-hmm. Cool. Then we need to know about readiness and capacity. So we need to know how many providers there are, but also how ready your providers are to deliver palliative care. Palliative care is very different from hospice care. It actually has anticipatory issues. You have to know about treatment. You have to know about side effects from treatments, all of those things, because people are still engaging with treatment planning. And you also need to know about how to coordinate care and resources and navigate other benefits, because things like hospice are just so standalone. But if you're delivering palliative care concurrent with other services, how are you going to coordinate that treatment plan alongside your colleagues? So that's the readiness. And then from a provider competency perspective, this is where there's a real opportunity to cross-train with oncology nurses, with cardiology nurses, with pharmacists who are actually doing other things, help them understand what the critical components of palliative care are, and then also learn from them about what advanced interventions are available, what the side effects from treatments are, all of those things that really allow us to not only have the skills to deliver palliative care services, but also the knowledge about how people and the population is changing over time. One of the things that I really like to do, and I think was reflected, Connie, in what you were sharing earlier, is, every community is different. And so what worked in Hawaii is not what's going to work in Maine. And what I found was that what worked in California was not something we could go and take to Hawaii. It's a very different population, very different culture, with very different workforce and geographic issues. And so what you need to do as a community is contribute to what your community capacity is and what your community needs are. There are certain things that can help when actually gathering feedback from your community. The first is the eligibility criteria for palliative care services. So who would be most appropriate for services? With Maine as the oldest state, you may have other issues. You may have a higher likelihood of dementia. You may have people with more frailty. You may have people just living longer with no evidence of disease. These are going to be things that are a little bit different than, say, California, that has a high diabetes rate, where people have complications from diabetes. And so we needed to add cirrhosis to the eligibility criteria. These are things that we need to understand from the community about what you actually need. You also have a very different workforce and workforce availability, especially as a rural state, than a place like California or Hawaii. And so we need to understand or determine provider capacity to deliver services, the competencies and the training that you would need in order to actually develop a workforce that delivers interdisciplinary care. Health insurance companies are also, including state Medicaid programs, are also just not super innovative places. I've worked in a lot of insurance companies, and they're pretty like black and white, right? And so if you're waiting for an insurance company to tell you what the ideal model of palliative care is, you will be waiting for 30 years. And you will never get paid for what you do. So part of this is taking the National Consensus Project Clinical Practice Guidelines, your Bible, and saying, this is the ideal care model for palliative care services. And we are going to be upholding what our clinical society is telling us is the right or ideal model. If you're confident about what you're delivering, then payers will pay attention to that because they want to make sure that there is a high standard of care that their members get. In addition to that, payment models are not going to include, oftentimes, the upfront capital investment that it's going to take you as providers to actually make this change from a fee-for-service, consultative palliative care program to a team-based, interprofessional palliative care service. They're just going to expect that that's what you will do in order to get money. And so being able to contextualize what you need up front and what, say, the Hospice and Palliative Care Council or the advisory group can do to help with readiness is going to be very valuable. That's a way that you can leverage your council as a group. It's important that as a community you actually start to source the expectations that you have for outcomes, your expectations around quality and reporting, and that you make quality and data and reporting actually something feasible for you. We all know that EMRs do not work as advertised and that they're only billing systems. And so when we're asking to document some of these things, we also need to know what is feasible. The state will love you for that, and health insurance companies will love you for that, because we don't want to ask you for something that's overly burdensome or is something that you can't achieve. I mean, that means there will be less of you, which isn't really the point. In addition to that, there are critical components of getting people access to palliative care more than just benefit coverage. And that includes public engagement and messaging. How do we want to message palliative care as a community? Provider education and training. So where do we need to beef up some of our educational efforts or fellowship programs or other educational institution programs so that we have enough of a workforce to meet this growing need? And then what consumer protections need to be in place so that people can start to call in and ask for palliative care. That's the world that I want to live in, that people feel like they can trust the product that they're getting, especially in light of all of the private equity concerns or challenges, or Hospice of the Lakes? Sounds about right. Especially in the certificate of need state. Not in a not certificate of need state. You get flooded when money comes into the state to pay for palliative care. You just get flooded with who knows what. As part of this, My team has developed a standardized policy design process that includes community-based participatory research as part of policy development. And we take all of the past experience of palliative care expertise in the state, work with state advisory councils, take the policy experience from other states, and then match that up with the National Consensus Project Clinical Practice Guidelines, guidelines from CAPC and from NQF, and all of the data we already have about the business case for palliative care. And I have not found a state where palliative care costs more money to deliver than it saves. I mean, it's just a no-brainer at this point. We just have too much data to say that it's the right business case. What you have to do then is source the community and find out if the benefit design that is being proposed is something that will work. That is so critical and is a way for you to get involved and to actually contribute the information, the data, and the feedback that you have. Because we haven't been delivering palliative care in a standard way across the country, and there hasn't been standard billing codes or standard benefits, we actually need to lean on qualitative data a lot more than in other places because you have the history, you have the knowledge, you have the experience. Claims doesn't reflect what experience you're having right now. So what I encourage is even when you're starting to develop these benefits and when you're starting to roll them out, that you get rapid cycle feedback in order to make sure that these things are working and that there's really clear guidance at the state level about what you need to do, what data you need to collect, and really engage with the policy-making process. That's only going to make technical implementation and utilization of these benefits more effective. There are a lot of data already to demonstrate that palliative care works. There have been hundreds of millions of dollars poured in to palliative care benefit design across the country that actually now is just a cookie cutter process that states can implement. So the Hartford Foundation, California Healthcare Foundation, Stupsky Foundation, the Gordon and Betty Moore Foundation, all of these palliative care foundations nationally have created a body of evidence that states can use to implement palliative care benefits, and especially for Medicaid beneficiaries. So I'm going to go really quickly through this design process so that you can get a sense of what folks like me in care have to think through, because there are a lot of questions that need to be answered in order for a benefit to be designed. Actually, there are 11. So if you look at these questions, I mean, where would you even start? It's pretty daunting to create something from scratch, right? All of these things could take a really long time. And so to leverage other states and their ability and the private market and their ability to contribute data actually fast tracks this process really well. And it's one of the reasons why we wanted to develop the National Academy for State Health Policy Serious Illness Institute, so that we were putting all the data in the middle for states, that you didn't need to recreate the wheel in order to actually get things moving. Because people and families cannot wait for us to get it together. So, somebody asked about the business case. People facing serious illness have consistent goals. Palliative care addresses those goals. Most people facing serious illness receive low-value, undesired care. Palliative care prevents low-value, undesired care from being delivered. Palliative care is one of the only things that I have seen that addresses the quadruple or quintuple or however many aims there are now. But it saves money, it improves quality of life, and it improves population health. And those are things that it's the trifecta that me in public health, I was looking for. We know that the best home care models have standard elements. So it's actually not that willy-nilly. Like there are standard elements that we can tie payment to. And if you're going to build a team, you need different reimbursement. You can't build fee-for-service for something that includes a nurse, a social worker, and a chaplain. It just doesn't work. And you want it to be 24/7? You're only thinking about some managed care or value-based care model. So you always start with the definition. And one thing that happened during COVID is that the federal government actually put out a definition of palliative care. They forgot to tell the palliative care community when they did it. They just sort of issued it on the Federal Register, but now it's here for you to reference. So any states that are actually trying to engage with the federal government about what palliative care is, they've just used the federal definition. And I put up here the main definition of palliative care. Now, Marion, that is not the consumer definition of palliative care.
Thank you for clarifying.
But is this what the council worked on? That looks familiar to you. So when you have an advisory council, this is what advisory councils do. They adopt a standard definition of palliative care that then you can advance a benefit against. If you don't have a definition, you don't get a payment model. That's sort of how it works. So you guys have that box checked. Then the question is, where does it fit in? So in Maine, as I said, you have a health home. So that's on this right-hand side. You also have all of these other benefits available to people with serious illnesses. Home health, hospice, home and community-based services. So the big question for a Medicaid program is, where does palliative care fit, and does it need to be standalone, or can I roll it into something else? How can we make it easy to sort of deliver this type of care? And so you'll see in the services section that a lot of these things look similar. And so the important part is to hear from the community why it needs to be different, why it needs to be standalone, what the goals are for palliative care, and how home health or hospice or home and community-based services just don't meet those needs. That then allows you to sort of create a continuum of care for people with serious illness. Then there's the real data. We need to identify who the population is, what their baseline utilization and costs are, what we can afford to pay for palliative care in order to break even or save money, and then determining what the cost is of delivering the benefit so that we can pay providers differently, but pay providers enough to deliver the services that we want delivered for this population. Even more questions, right? So thankfully, NQF put out in 2019 this picture. This is a public picture, and it actually works to tier palliative care. So if you look at the whole population from a population framework, you're going to have a pool of people who are not seriously ill. Then you're going to get people who have a diagnosis of a serious illness but are able to manage on their own. And maybe they're a good candidate for a palliative care consultation, or they're a good candidate for advanced care planning. But who needs that finite resource that is specialty level, team-based palliative care? I would say that's somewhere in between A and B here. Would you agree? Where C is sort of hospice. And this is a good framework to think about when you're talking about, what the eligibility criteria should look like and how to make it flexible. So we've been analyzing data from more than 20 states, and what's interesting is that population trends are pretty similar. And we've been working with the National Coalition for Hospice and Palliative Care to really match up and look at what are the adult conditions or population trends in adults as well as the population trends in children. And the claims data across all of the Medicaid agencies that we've worked with have really given us this list of disease categories where people are really appropriate for palliative care services. So this is just from the data. Who is utilizing the hospital or the emergency room to manage their pain and symptoms of a serious illness? Does this look familiar to you? Is this the population you take care of? Wouldn't it be great to get paid for the services you deliver to the population? So look, we've already found the population, the eligibility criteria. So if you think about then what you need to do, yes?
In that list of medications, I assume insurance companies see that and see a lot of money.
Oh, for sure, right? What you see is that these individuals are accessing the hospital to manage pain and symptoms. They'd really like for that to stop. I mean, and so with the patients and families going to the hospital for dyspnea and vomiting, right? Or high-risk maternity. So if you look at this, when you're building out an alternative payment model or a value-based payment model, you need to know or help the state or the insurance company know 4 things. Who's eligible for services, what outcomes you're trying to achieve, who the care team is, and what services the team provides. And those are all the things that make up a payment model. So you too can be an actuary. What we're seeing as a going trend across private insurers and state programs is this idea of a bundled payment approach to care. And a bundled payment has 3 elements. One is payment for a palliative care assessment to determine whether or not somebody needs specialty level palliative care services. The second is a reassessment, which determines or reauthorizes how long somebody needs palliative care services. And then the third is a monthly payment rate to cover the services delivered by the interprofessional team. And that allows you to be more flexible in how you deploy your services based on somebody's individual care plan. And so if you see that, that's something that takes the fee-for-service widget by widget model and sort of rolls it into something that's a little bit more managed and allows you to staff differently for your programs. So you said something about they see a lot of money, right? Well, this is California. My friends Brian and Kathleen and I had this opportunity to evaluate SB 1004 after 5 years of implementation. SB 1004 is the Medicaid palliative care benefit that was rolled out throughout the state. And what we found was that palliative care saves money.
No.
Like a lot. And what was interesting is that the way that this started out with the insurance companies was it was a mandate. It was what they called an unfunded mandate, which meant that the state was going to require the health plans to deliver palliative care services, but they weren't going to give them money to deliver the palliative care services. And so the state took a bet, and they said, look, we believe that palliative care saves money, and if you roll this out, you will too. The health plans argued and complained and hemmed and hawed and said they needed money. And then they got these results, where they saved somewhere between 42 and 51% total cost of care for their population. And then they begged the state, hey, please don't take our money away because of all our savings. They wanted to keep the savings. So what we saw in California after 5 years was that health plans expanded the eligibility criteria for palliative care services. They actually increased rates for palliative care providers so that you could actually grow your team and your workforce. Now there are commercials, literally, on television for palliative care by insurance companies. in multiple languages. It's hilarious. I like living in California where my doctor asks me about my advance directive and palliative care availability. And that's something that can happen anywhere. So in terms of what we've learned through this process over the last 7 years or so, is that palliative care saves money. It's also the right thing to do. It saves more money than it costs. And so you can reallocate savings from hospital admissions, ER visits, etc., to pay for a pretty robust palliative care team, a specialty palliative care team. And palliative care, when implemented correctly, also increases the length of stay, not only for palliative care, but also for hospice care. And so it actually gives people a much longer care continuum across the board. People accept hospice at a higher rate when they have palliative care first. It's not such a false choice anymore. Some of the challenges that we've seen are that it's really hard to find palliative care providers. It's also really hard to find the overall costs of delivering palliative care because claims only have part of the story. In addition, there are certain places that just have lower costs. So for dementia patients, for example, they often avoid care. They don't cost a ton of money. It doesn't mean that you shouldn't include people with dementia in your palliative care program. So when we're talking about savings, we're talking about, savings overall, not just savings to individual people. I have two last pieces, which is about if you are so fortunate to start getting paid for team-based palliative care services, there are things that you need to do in order to get ready. And some of the important pieces are really about policies and procedures and expectations for delivering services. So states are actually working to improve implementation by developing shared documents, clear policies and procedures about how to operationalize these National Consensus Project guidelines. We have found that palliative care utilization starts really low. Most people, if they think it's hospice care, then the utilization rate for palliative care starts out as basically the hospice utilization rate for the state. So you have to sort of work at getting people to understand the difference and to understand that palliative care is something that isn't hospice, with all of the messaging elements. No hands. But it's really important to include your provider or specialty colleagues in this process. What we found is that specialists are actually the best advocates for referring to palliative care. And if somebody's specialist or primary care provider is not on board, the patient is highly unlikely to accept the services over time. The biggest barrier to cost savings is awareness. The biggest barrier to cost savings is awareness. It's not actually anything else other than people knowing that it's available. And in order for you to get paid for palliative care, you need to standardize your model. So there are going to be more requirements about what you do to deliver palliative care if you want to get paid in a standard way for it. You can't put a lasso around the Wild West. So you have to agree on the rules. And that means working as a community to develop assessment tools and eligibility screening tools and care planning documentation and data and reporting standards at the state level will be really beneficial for you as providers to be able to do something in a standard way. So to take away, state agencies and health plans can't afford not to deliver palliative care, so you're a critical component to any of their business case. Enrollment is the driver for savings. So you actually need to give people the services in order to save money. Baseline costs are very high for this population. And even as an actuary, when I saw the numbers, I just could not even believe how many people cost so much money with a serious illness. Most people who are in finance look at primary care, or they look at whole populations rather than this small population of people with serious illness. So helping people understand that these numbers are real and that it's very financially toxic to be seriously ill is really important. Include the community in your benefit design work. And I think this is where the council is in a great position to do a lot of that convening and get feedback from all of you. And then there are 3 places to really focus if you want to have optimal implementation. One is public engagement and education, awareness campaigns about what these services are, workforce training and capacity building. So making sure you have an educated workforce to implement this correctly. And then technology and data infrastructure so that you're documenting accurately and you're able to demonstrate that there are actual results happening here. And then make sure that you approach this from a quality improvement framework, knowing that you're not going to get it right the first year, you're not going to get it right the first couple of years, but you'll improve as a community over time. So learning communities and rapid cycle evaluation is really what we're seeing state Medicaid agencies adopt.